Welcome to our video on dermal melanocytosis and Erythema toxicum neonatorum. Let's get started. So here's a brief overview of the topics that we're going to cover, and as we move along during this lecture, pay particular attention to the appearance and location of each rash. So let's start with dermal melanocytosis. And just so you're aware, we're going to follow our typical pattern of discussing the definition, pathophys, risk factors, clinical presentation, diagnosis, and management. So dermal melanocytosis is characterized by blue-gray pigmented patches and is the most common pigmented lesion in newborns. And these patches are typically found on the low back and buttocks of infants. And here's a picture of what dermal melanocytosis looks like. Note these two blue-gray patches in the region between the low back and buttocks. Dermal melanocytosis is a benign condition that stems from abnormal deposition of melanin. Normally, melanin is only deposited in the hair follicles and epidermis, but in dermal melanocytosis, melanocytes produce melanin in the dermis. Hence the name. It's dermal melanocytosis. Now, melanin, when it's in the dermis, scatters light and it produces this bluish color. So basically, all this condition is melanin that's deeper than it normally is. So dermal melanocytosis is actually really common in certain ethnicities, specifically Asian, Black, and Hispanic newborns. And it's actually pretty rare to see this in Caucasians. Now let's talk about the clinical features. Well, dermal melanocytosis typically presents at birth or within the first few weeks of life. And the lesions are flat, non-blanching under pressure, and that makes sense because it's just melanocytes deeper than normal. So you wouldn't expect any raised lesions or any blanching. Now, an important high-yield point to remember about this skin condition is that it's often mistaken for child abuse because it looks like a bruise, looks like somebody was hit, or it might resemble a bruise from a coagulopathy. So how do you diagnose it? Well, it's actually diagnosed clinically, thankfully, and the parents can expect it to fade away within the first few years of life, and most of them completely disappear by adulthood. And since this condition is benign and fades on its own, then you don't need to treat it. Let's do a quick question. What is the difference in clinical presentation of congenital dermal melanocytosis and congenital melanocytic nevus? Congenital dermal melanocytosis and congenital melanocytic nevus are similar sounding skin conditions that can present in the early years of life, which is why it's so important to distinguish them. Now, congenital dermal melanocytosis, also known as Mongolian spot, classically presents as a flat, poorly circumscribed blue-gray patch on the lower back. And as we learned on the previous slide, it fades with time and doesn't require treatment. But what about the other condition? Well, congenital melanocytic nevus develops as a result of benign proliferation of melanocytes. So notice that in this condition, the nevus, that it's proliferation of the melanocytes, not simply melanocytes and melanin located in deeper tissue like the dermis. And congenital melanocytic nevus typically presents as a hyperpigmented flat or raised lesion with overlying coarse, dark hair. And unlike a congenital dermal melanocytosis, this lesion doesn't fade with time, and it's often removed surgically. And knowing these key differences should actually be sufficient in confidently distinguishing these two skin conditions in real life and on exams. Next, we will discuss Erythema toxicum neonatorum. And here are the 5 points that we're going to discuss, and start with the definition. Erythema toxicum neonatorum is a benign pustular rash that presents within the first 2 weeks of life. And there are a couple of documented risk factors for this condition. The rash tends to occur more frequently among babies who have a higher birth weight and have a greater gestational age. So how does it present? Well, the rash typically presents in the first 2 weeks of life, and it's completely asymptomatic and is described as having papules and pustules on an erythematous base. And the rash is mainly distributed along the trunk and the proximal arms and legs, and the palms and soles are spared. And this feature differentiates it from similar looking rashes that include the palms and soles. So let's take a look at what this looks like. And this rash is diagnosed clinically and does not require any laboratory testing. And since it's benign, you actually don't need to treat it. However, it's important to reassure the parents that the rash is benign and will resolve with time. So here's a table summarizing the most salient and high-yield concepts discussed in this lecture. And you may find it useful to return to this table when reviewing these common neonatal rashes before your exams. And as we continue with the next neonatal rashes lecture, this table will actually be expanding so you can compare these two conditions with the conditions we'll discuss next. And before we conclude this lecture, let's wrap up with a multiple choice question. A 2-month-old girl is brought into clinic by her parents to establish regular follow-up with a pediatrician. The family recently immigrated from Sudan. According to the parents, the girl was born full term via an uncomplicated vaginal delivery, and the mom had appropriate prenatal care. They haven't had any concerns regarding her growth or health to this point. The girl has not yet received any vaccinations. The girl's length is at the 60th percentile, weight is at the 70th percentile, and head circumference is at the 50th percentile. A head-to-toe examination is largely within normal limits, with the exception of a dark gray patch on the baby's bottom. The patch does not appear to be tender to palpation. Parents say it's been there since she was born. Which of the following is the next best step in management? A. Reassurance. B. Contact Child Protective Services. C. Skin biopsy. Or D. Ultrasound of the sacrum. So the correct answer is A. Reassurance. So this is a case of an otherwise healthy baby with a dark gray patch on her bottom, which, according to parents, has been present since she was born. And that physical exam finding and history is consistent with a diagnosis of congenital dermal melanocytosis, sometimes called a Mongolian spot. And recall from this slide that treatment is unnecessary, and they typically fade within the first few years of life. And for this reason, reassurance is the next best step. Now, option B, contact Child Protective Services, may be tempting because Mongolian spots often look similar to bruises that may manifest as a result of child abuse. However, there's no reason to suspect child abuse in this patient, as she appears to come from a stable family. Granted, you can't always tell just by this one visit with the parents and child, but there aren't any red flags. And also, appropriate measurements are seen, like length and weight and head circumference. And the fact that the parents' response is that the lesion has been there since birth is consistent with a diagnosis of Mongolian spot. If they were to say something like, I was having a hard day, or something like that, then you're like, okay, child abuse, but there's no red flags. So assume Mongolian spot. Now, option C, skin biopsy, is incorrect because congenital dermal melanocytosis is a purely clinical diagnosis. So you're not going to biopsy that. Now, lastly, option D, ultrasound of the sacrum, is incorrect because congenital dermal melanocytosis is not associated with any underlying pathologies. However, if the baby had a sacral dimple or a tuft of hair on her lower back, then ultrasound of the sacrum may have been appropriate actually because it can help you identify spina bifida. And that concludes our lecture.